everybody. It's Kevin and Donna from RPH Ally. We're so excited to see you guys again. So the Deprescribing show, we put some little alert buttons up there because we're on high risk meds today. I'm going to play our reel, and then Donna are going to jump right in. All right, so do remember that our sponsorship on this is all about Donna and her awesome book, MedStrong. And so with that, go ahead and pick up that copy, go ahead and check that out. But I feel like I need to become more MedStrong and high risk meds. And the reason why, Donna, is because way too many patients that I have seen, these are exactly the reason why I saw them in the hospital.
Yeah. Absolutely. Yeah. So, thinking about high risk meds, there's so many different lists out there, and high risk meds can mean many different things. But what we want to be thinking about today is thinking about those with a narrow therapeutic range that can really make a big difference in people. So, small changes, big differences. And think about all these topics that we've been discussing throughout the weeks. And we know older adults are more sensitive, right? They're more sensitive to these side effects and issues. Well, it's also the same thing for meds that have narrow therapeutic range. So, I mean, there are a number of meds that we could be speaking of today, but we're going to just talk about a few. And I think a few of them are really important in regards to thinking about our older adults, maybe some confusion that can happen with the dosing of the medications, and a lot of tweaking goes on with these particular ones. So which ones am I talking about? Talking about levothyroxine, I'm talking about warfarin, and I'm talking about insulin. And these are things that have a lot of changes as we go through, because we're doing basically a lot of adjusting for these. And small adjustments can make big changes in our older adults. So, so first of all, I think the first slide here, Kevin, is about levothyroxine. We can just talk about this one, then get into the other ones later on. But when we're thinking about levothyroxine, we become more tolerant with TSH levels, just like we do with, for example, A1C and people with diabetes, right? We allow for a little bit higher A1Cs in our diabetic patients. So the same concept is also similar for thyroid. And this has been like kind of like a bee in my bonnet for a lot of years, I must admit. And I kept many years ago, I had a file of things I wanted to investigate more and write on. And one of the things was, what should the TSH levels be in older adults? And here we have it, right? There are reviews out there and information from the thyroid associations that talk about actually allowing for a little bit higher TSH in our older adults. So why does this matter? Well, when we have lower TSH levels, we know that that means more of a hyperthyroidism. So what happens when people have hyperthyroidism, or if they're over medicated, right? We're always talking about being over medicated on products. And this is one of the items that people can be very over medicated on. So what's happening? Oh, heart palpitations, right? Someone's now having heart palpitations, and oh, now they're in the hospital because of heart palpitations, and their TSH could be somewhat on the lower side. So that's one of the issues that we could be having a problem with. Now, there's also thyroid. So with the thyroid issues, there's also diarrhea. You could have someone not being able to absorb products well. They're just having intense diarrhea. That could be because of too much thyroid medication. Also, things that happen are increased risk of fractures. So the higher the dose for thyroid medications, the higher the risk of a fracture. Go figure, right? So why is this? Well, we know that hyperthyroidism can reduce bone mineral density. So what are we doing in our older adults if we're doing really low TSH levels and saying, oh, all right, you're in range? we don't want to be doing this. We don't want to be depleting people that have, osteopenia or osteoporosis and putting them on doses of thyroid medication that is allowing them to be in normal range, but it's the lower normal range that we want to try to avoid. So where should people be? Well, probably around 4 to 7, believe it or not, for the TSH. And we never think about that, right? We're always trying to be between zero point 0.4 and 4, maybe. I've also seen around that 0.4 to 3.5s. Those are low. And those are considered lower for our older adults. So be thinking about that. Be thinking about moving that TSH up. It's still considered to be an okay thyroid level in our older adults. It will reduce fractures. It will reduce palpitations. Um, and hopefully some other issues that people might have that would bring them to the hospital.
Why
The
don't we
other
see
thing, yeah,
why don't we
yeah,
see those kinds of lab monitoring components? Because I love your graphic here about the sliding age component, like showing your
right,
TSH will go up normally. But when you and I see laboratory evaluations, like they're always standard based labs. Like this is the range of a quote unquote typical individual. Well, guess what? No one is typical. And two, when you hit certain age thresholds, you don't
yeah,
have that. So have you worked with your institution, or have you seen other institutions pushing for alterations like with TSH, which I also have a B in my bonnet about it, when it comes to changing the way we graphically represent those to our clinicians and our pharmacy professionals on what they're seeing in range and out of range?
right. No, I haven't, Kevin. I really haven't. And this is frustrating to
Mission for
me
Donna
in
and Kevin.
regards, say it again.
I said there's a mission for Donna and Kevin. Like I think
Yeah.
that display is just, someone sees their labs, they come home, they're worried about it, they go and see their primary care provider, and then
Mhm,
all of a sudden we have a change in dosing for levothyroxine,
mhm,
and then we
mhm,
see it, geriatric deprescribing professionals and think that's
yeah,
not a necessary change. This is actually within normal range. It's just a part of
right.
aging in general. You can
Mhm,
start monitoring these kinds of things by looking at what does thyroid hormone absence or presence actually do in your body. So if we're seeing
yeah.
some of those things symptomatically, that's what is a
Mhm,
more appropriate adjustment as opposed to just chasing a number and trying to base. And this probably is for me, Donna, back in the long-term care days when it was something is wrong with Mr. Jones or Mrs. Jones. It must be their
mhm,
thyroid. Let's go and look at it and make a change, and that's going to fix it. So we just too often take a symptom and try to
mhm,
attribute it to an individual drug rather than think about the complexity. So I just love that you
right.
bring this.
Yeah. So, and then if we think about it, right, what else does thyroidism bring with it? But anxiety. People get very anxious on it, and
Yes.
if your heart pumping out of your chest, well, yeah, that's going to make you very anxious too. So that's another thing. So is somebody that's a prescribing cascade that could occur as well. If people are feeling anxious, but they still have good thyroid levels, but they could be on that lower side. They might be feeling that anxiety and not realizing that it could be medication related too. So there's a lot of things that, as we age, and if you think about it, women are more likely to have hypothyroidism, and they're more likely to have fractures, and they have increased anxiety as they age. And so, you can see all of these things that are happening, and it
Yes.
could very well be just this over medication. So I'm always asking for TSH levels at the hospital, or like, or if they can't, work with someone who um, has a high resting heart rate, I'll often say, well, what is the TSH level? Have you checked that?
Mhm.
Because they're having a hard time regulating a certain heart rate for the patient. So even just trying to get that down, just trying to get an understanding, it's a good part of the picture.
Awesome.
So,
Insulin
um,
next.
yeah. No, not yet. I want to bring
Oh,
up another thought with the levothyroxine as we talk about this a little bit more. We'll get into the other stuff later on. But
perfect.
um, but how often have you seen changes on how someone takes their thyroid medicine, right? Skip Sundays and Wednesdays. And we start getting into like, okay, what day is it? Am I skipping? Am I taking? Right? So
All the
how do
time.
we look at that? Right? How do you look at that? So because you're trying to target a particular number, so they're a little bit over 4, that's an issue. Like I don't think that that's that by increasing these thresholds a little bit, we might be able to reduce confusion of changing meds as well, or changing days. So I think part of it, I think it might be a good test, if you will, to see if it is thyroid, if it helps to maybe skip a day for a month or so, just to say, like, all right, skip Sundays. And I think that that can be okay. But once it's resolved, like once you know, like, okay, this is better, redo the week average of the thyroid med and dose appropriately so that it's an everyday dosing again. So reduce that dosing as you can. Once you start skipping 2 days, you have way too many highs during the middle of the week. You can't be doing that to someone, because by the third day that they're taking something and their levels are higher, guess what? They're starting to feel anxious. They're starting to get palpitations. They're not feeling. So there are these issues. So we need to make certain that we are trying our best to keep things as level as possible for people who do need treatment, and keeping it as low as it can possibly be to prevent some of these issues from occurring.
Just from adherence data alone, Donna, I mean, you and I know,
Mhm.
we've seen the studies, we've seen some of the tools that are in place that say if you put a patient on a medication that's taken more than once a day, the adherence rate drops significantly. If you start changing the
Mhm.
days that they're taking them and not taking them, once again, large drop. And guess what? Taking a multivitamin once daily, already the adherence rates are relatively low for a large portion of the population. And so
Mhm.
adding those complexities on, I can't agree more. Like we try to over science things and don't remember, like, you have real human beings trying to take these things and remember when to take.
For sure, for sure. So, we will be talking more about insulin and warfarin, but some things with insulin, and I'll just do a little teaser right now, is to be thinking about someone's kidney function, right? As we age and as people have diabetes, and kidney function typically declines. So what do we do with the insulin, right? So that's going to be really important to talk about. And then also, again, thinking about complexity and confusion with doses and when to take and how much to take and testing, and also thinking about warfarin in that regard too. We tweak a lot because we have to, but we have to also make sense of it for the individual. So,
I
Kevin, I
love
just have
it.
to say, for the first time since I've been doing this with you, this is the first day that it hasn't been dark out and the sun's already been down. The sun's up still. Isn't that pretty cool on here on the East Coast?
Nice. Yeah. Yeah, I did have a couple people that we do these lives with, Donna. They're like, I've got to change my lighting because it's pitch black
Right,
where I'm
I know
doing
it's coming through. I have the window crossings of.
it. That's so nice. Yeah, so for everybody, thank you so much for joining Don and I today. And the sun is out, the levothyroxine is being talked about. We're trying to just, up the mood altogether. But with
Mhm.
the levothyroxine kind of nuggets from Donna, a few of the key takeaways to be able to bring from this show are really going to be: playing with dosing and skipping days can sometimes be a confusing thing for everybody. It can have some utility, but being able to avoid that and make it simple, better for institutional and non-institutional settings. Other piece that Donna showed in that graphical representation is that our need for TSH tight monitoring windows, as opposed to larger like viewpoints and parameters on those TSA measurements, change with age. And so we need to consider that and not look at every laboratory value that comes to us and say, oh no, they're out of range, I need to make a medication change. Donna, did I miss anything on there?
No, you nailed it. That's perfect. Thank you
I
so
tried.
much, Kevin.
Good student for you. All right, everybody, we'll see you on our PH Ally.
Absolutely.